What happens when a patient can't communicate their fears, pain, or even understand the care they're receiving? Today's episode explores language barriers, social determinants of health, empathy, and the moments that transform nursing students into compassionate advocates. We'll hear how one student discovered that nursing is about far more than medications and charting. It's about human connection. This is Care Beyond the Chart, Strength Behind the Scrubs. I'm your host, Misty Burgett, and today I'm joined by Tracy Espinoza. Tracy is a nursing student at a local community college, and she's here today to talk about a clinical experience she had taking care of two non-English speaking patients. Hi, Tracy. Let's start with letting you tell us a little bit about yourself and what drew you to nursing.
Hi, Misty. Hey, everyone. My name is Tracy, and currently I am a nursing student at Ivy Tech Community College. I have the pleasure of having Misty as my instructor there.
Thank you.
I have been in healthcare since 2019 now. I've been a certified medical assistant at Parkview. I've only ever worked at the walk-in clinics. That's all I know. But it has helped me shape a good clinical background for knowing things and not going into clinical just like, I guess,
Totally agree.
yes, like a deer in headlights. But I've been a medical assistant for 7 years now. Yes, 7 years now since 2019. The Parkview Walk-in Clinics is the only job I've ever had. And I took it as a stepping stone into starting my healthcare career. I knew that essentially I wanted to do more than just be a medical assistant. I love being a medical assistant, but I want a scope of practice that allows me to do more than what I can do as a medical assistant.
Sure.
So that was one of the biggest reasons why I wanted to continue my education. I do kind of sometimes had the ideas of even going as far as getting my nursing practitioner,
Nice.
just because, again, I know that within our Hispanic community, there isn't a lot of practitioners that know about cultural background and things like that. So I kind of want to cater more towards that community and be able to provide like care for them.
I love that because one of the things that is very important to me as a nurse and as a nursing instructor is attracting more students of color into the profession, because I think it's important for patients to see reflected in their nurse, like mirrored in the nurse backgrounds that they represent too.
Yes.
I think it builds trust in the healthcare community when they see that reflections.
Yes.
I love that.
Yes, I really do agree with that. I know I've experienced it with seeing family members being in the hospital and things like that. It really does make a big difference when you have a healthcare provider that can relate to not just your culture, but sometimes also towards what your family say in that culture and things like that. Like the big picture, the holistic care of it.
Yeah.
And so that's one goal that I do have in life. Like that's one of my biggest things that I aspire for, and I hope that I can do one day. So
Well, I'll be here rooting you towards that goal.
thank you. Thank you. I really appreciate that. But so, yeah, I am originally from California. My parents are both from Mexico. So I grew up with a very strong background for our community and things like that, being close to Mexico. And just, with our culture, we lived it, not where we lived in California. It was a big Hispanic community, where I went to elementary school. Literally, you could count on your finger the other kids of color. The Hispanic kids were the majority there. And
Gotcha.
Caucasians, African Americans, Asians were all the minorities. Yeah. And like even our principal was Caucasian, but she spoke both English and Spanish.
Aw.
Yeah, because that's how big the community was over there and things like that. So,
what surprised you most about nursing school so far?
and exams? The exams, yes. The exams are scary. Yes, the exams are scary.
All the possible questions are correct.
You're right.
Pick the most correct.
Yes, the most correct. What's the most correct?
Like, what does that even mean?
Oh my God. I think I finally understand what it finally means. I really do. I think it's got to be how you approach your critical thinking skills, really.
Yes, absolutely. Has your understanding of patient care changed during nursing school and in participating in clinical experiences?
Yes.
In what ways?
Yes, because during the clinical experience, with it being mostly like med surg and things like that, I learned to focus on just 5 to 6 patients instead of, whereas I'm an outpatient, I see 50 plus in a day.
That's a lot.
Yeah. Oh my, tell me about it. That's one of my most mental exhaustion things at work is just how many people you interact with.
Yeah.
Yeah. So just being able to establish the relationship, the working relationship with the patient that you're caring for. In outpatient, I also establish a relationship, but it's going to last 15 minutes or less.
Right. And then versus all day, a 12-hour shift with the patient.
Yes. I mean, I have my frequent,
right, that you see.
Yeah. And stuff like that. And those you establish a actual, not just a working relationship, but you establish a relationship, whereas they come in and they ask, oh my gosh, is Tracy working today, type of thing, and whatnot. So, but in inpatient, I learned that you can have more of like that one-on-one with them, and you're gonna see them today during your whole shift that you're there, and then if you work the next day, you possibly have them again and things like that. That the outcome of what their stay is because you've been with them throughout the whole thing.
So there's one clinical experience that I know you had because I was your instructor on this particular day that I want to talk about. And that clinical day would completely change maybe how you viewed communication, trust, patient advocacy. Can you talk a little bit about that day that I assigned to you 2 non-English speaking patients?
Yes. So that day I had 2 non-English speaking patients, and one of them I remember was around my age group. So him, I thought it would be a little bit easier to communicate with him just because we were in the same age group. But he was very much, you could tell that he was very much depressed being in the hospital. And the fact that he had somebody that spoke Spanish in person to him made a difference to him. I could tell it made a difference. But still, I could also tell that he was worried about something else. You could still tell that he was not 100% open with me and whatnot. So I kind of dug a little deeper in his chart, and with him in person too, we kind of conversated a little bit. It was amazing to see that he gave me a smile when he saw that I didn't have to reach for the iPad to talk to him.
To use the language line interpreter, video interpreter.
Yes. And he was still, you could tell he was sad. And I know being in the hospital, people can be sad, but I saw in his chart under the social determinants of health area that he was uninsured. I knew that within our community, a lot of people are uninsured. In my head, I was like, he's probably worried about the financial outcomes of this hospital stay. I talked with him and I let him know that in his chart, I had seen that they had already initiated a social worker to review his case. And I let him know that they were reviewing the cost of medications for him, reviewing, applying for insurance for him and things like that. And by the end of the time that I was there for that clinical day, I did actually get to see that his medications were covered. So I was able to let him know that his medications were covered because that also played a big factor for him.
And it's being fearful. I remember you coming and talking to me about that situation and saying, we need to talk to the nurse and make sure that they are working on the insurance aspect, which you said you discovered they were. But I think the disconnect maybe for him was he didn't completely understand that they were taking care of that.
Care of something and working on it.
Speak his language. Yeah. They're trying to communicate this through the interpreter.
Yeah. And even sometimes when they use interpreters, yes, they are relaying what the English speaker is saying, but sometimes that empathy isn't there.
Right. The nuances of that communication are lost.
Yes. That therapeutic communication isn't 100% there, even though as the nurse, you are communicating with the patient. Sometimes because your voice is being interpreted by somebody else, that same empathy is then transmitted.
Sure. Because they're strictly interpreting what you just said. And and they're not trying to build a communication therapeutic relationship because they're just doing a job.
And you don't always get the same interpreter either.
Right.
And
just each time you call in.
Yeah, because they can't always stay on hold for you and things like that. So I do feel like they just weren't communicating with him, letting him know that it was being worked on. And I remember that played a big factor in it because I remember going in to assess his pain and he would always rate it low.
Even though you felt like
Even though
displaying that he was in pain.
even though you could visually tell with him guarding his belly and things like that, and just his physical appearance, you could tell that he was in discomfort. Maybe not a 9, a 10 pain, but you could tell that he was uncomfortable.
Enough that he needed to be medicated. So what do you think? Why do you think he was rating it lower than what it was?
So that he didn't receive any medication, because he knew that every time he was receiving medication, it was another bill.
Gotcha.
So I really do think that he was not necessarily trying to be tough, but just worried
about that money aspect of it.
Yeah, about that outcome with the bill and things like that. So I remember that when I was able to tell him that his medication was at least going to be covered, I let him know, your medication's being covered. I can tell that you're in pain. Like, if I were to use the FACES scale, I could tell you're grimacing right now. You should at least be giving me a 4 or 5, not a 2, And his vital signs reflected somebody that's in pain.
Sure.
His lab work also reflected that he wasn't trending the way he should be trending. He was going backwards and stuff. So obviously, as a nursing student, that should come with some
discomfort,
some kind of discomfort. And so I let him know your medication's being taken care of. The cost of it is being taken care of. You don't have to lie about your pain. I can tell that you're in discomfort
and give you something.
There's different medications I can give you. If you're worried about something being opioid or something like that, I have something else that isn't that you can be given if that's something that you're concerned about.
Sure. Tell me about the other patient that you had that day too.
The other patient was an older gentleman. I believe he was like in his 50s. So when I walked in to take care of him, I really felt like I was walking in to like take care of one of my family members or something like that, just because of the age, the background. He was actually very easy to talk with, very, very easy to talk with. You could tell his whole mood changed when he saw a Hispanic young girl walking in, talking in Spanish with him and stuff. And the nurses told me that he spoke a little bit English so they could communicate with him, but they would still use the interpreter iPads and stuff. But you could just tell that his whole mood brightened up when he saw somebody that could fluently speak in Spanish with him. He was actually very fun to take care of. I got to know where he was from back in Mexico and things like that. He told me what his life story had been, what he was doing here and things like that. But what really struck me with taking care of him was that I believe he was going to have a PICC line inserted.
Yep.
So they were giving him, they always have to go in, review the procedure with you to get the informed consent. Of course, all of the education's in English. And so the nurse look up on, I believe it was on Elsevier, that's where she found.
Yeah. Initially there was a video that she said she had.
Yes.
But it was only in English.
Only in English.
She wanted you to interpret it, but we were getting ready to go to lunch.
Yes.
So we were like, when we get back, you were going to do that. But then
she found a article on Elsevier on the same procedure in Spanish. They gave that to the patient. So that was when we were in lunch, when we came back from lunch, and I went in to check on him, do vital sign check, blood sugar check, all that. I remember asking him, "Oh, did you go over these papers yet? Have you read over them? Do you have any questions? Are there any concerns I can help address for you?" And he tells me, "I don't even know how to read."
Oh.
And so,
if I remember correctly, he had been in the hospital like 10 days at that point.
Yes, he had been there for quite a lengthy stay, and he was actually there. He had been, I believe, at Kosciuszko first, and then from Kosciuszko transferred to. Yes. So he had already been there. In my head, I'm just like,
how did nobody know this?
How did nobody know that you don't know how to read? Yeah, they're giving you the information in your language, but they're assuming that you know how to read. They haven't even come in and asked if you have questions or concerns. So I let the nurse know, "Hey, our patient hasn't even reviewed this. He doesn't know how to read." And they're like, "Oh, it's in Spanish." I go, "I know it's in Spanish, but he doesn't know how to read."
And in his own language.
Yeah. And so they were shocked. I remember them being shocked. I let them know, oh, well, in our culture, at least in Mexico, a lot of our older folks, like once they get to your 50-plus-year-old folks,
Mm-hmm.
a lot of them didn't have the opportunity to have an education. You know, a lot of them had to work from young age to help their families. He must have never had the opportunity to learn to read or write. Even when you look at his signature, it's a shaky signature. You can barely
Mm-hmm.
make out some letters on it. So
Right.
that's also an
Flag.
yeah, an indicator that your patient has a disconnect there.
Mm-hmm.
And even English speaking patients can have that same disconnect. It doesn't have to be that he doesn't know how to read his own language. He could have had dyslexia or something
Sure.
like that, you know?
Absolutely.
But it got missed.
I think it's something that we make assumptions a lot,
Yes.
that everybody knows how to read and write.
Yes.
And I think that this brought up, it was really eye-opening because in that clinical, we had another student, one of your peers, who actually worked on that floor as her job. And I remember, when you talked about this in post-conference, her saying, "Oh my gosh, that makes sense." Because she had said when she had worked
Mhm.
and was taking care of him, she was trying to use Google Translate, and she was talking into the phone and then showing him the screen. And she said that he just kept saying, "No say, no say, I don't know, I don't know." And okay, now that makes sense. He couldn't read, and that's why he didn't understand what I was trying to tell him. I was so
Mhm.
confused. And so, yeah, that was, even for me, honestly, an eye-opening experience, that even if you have somebody who hasn't immigrated here from another place and speaks another language as their first language, born here, speaks English, whatever, making the assumption that they know how to read, or
Mhm.
even the dyslexia, that's another thing. And it's important for us to be, as nurses, to be aware. And then what you were talking about in your culture in Mexico, that oftentimes 50 and above may not have had the opportunity for education. That's something I didn't know. I just learned as you were saying it. But again, opened my eyes some more to the importance of culturally competent care and being open-minded and open to learning, and not just leaving it at assumptions and,
Mhm.
okay, this is going to be a difficult patient to take care of today because I don't speak their language and I'm going to have to use an interpreter. And I think that inadvertently, sometimes nurses maybe tend to avoid those rooms. They go in and they do what they need to do and they take care of the patient. But it's hard when you can't speak their language and you're having to go through an interpreter. And it's also not, what's the word I'm looking for? Not feasible to
Mhm.
every interaction bringing an interpreter in, because sometimes you're just going in real quick. And so then we're just trying to use motions or whatever to get to, like, do you need more water or whatever? But they probably don't the same level. I don't want to say same level of care, just that therapeutic relationship and therapeutic communication that's such a part of nursing that other patients might get because they speak the same language as their nurse. So,
Yes. And I think that with working inpatient, I think that that's very important because a lot of the times this patient, he had already had a lengthy stay. Obviously, it could also start to affect their mental health and they could become depressed. And then that later, yeah. And then it just makes it worse for them to try and heal and things like that. But again, I think that that's something that all of us as healthcare workers and whatnot should be mindful of, not making assumptions that everyone can read or write.
mhm.
Yes, we can all see that there's an X with the line that requires a signature, but that doesn't mean that we have read everything that's above that line.
And that we understand what all of it means.
Correct, because
For us.
even if I know how to read what I'm looking at, doesn't mean I understand what I'm looking at. The level
Literacy.
yes.
Yeah.
Health literacy is also a big thing, not just with patients who speak another language than ourselves, but also with people who we can communicate with in the same language.
I'll tell you, this experience, for me, it was kind of an evolution as an instructor, because prior to having you in my class, I'll be honest, I tended to avoid assigning students to non-English speaking students or English speaking patients because of the difficulty of navigating that, just not only as a nurse, but for me as an instructor with a student, and then trying to navigate that. I tended to just avoid that if I saw that on a chart. But prior to having you as a student, I had a mental health clinic where there was a Spanish only speaking client in a locked unit. And I mean, I noted it, didn't think a whole lot of it, and then assigned my students, patients, or clients. And when we went into that locked unit, one of my students surprising to me, just gravitated towards this gentleman and started speaking in his language. And I was like, I didn't know you spoke Spanish. And she then shared with me, oh yeah, I spent a year as an exchange student. I'm fluent in Spanish. And she ended up kind of pivoting, making him her assigned client for the day, and then navigating that day with him and sitting down like when he had to meet with the doctor and translating. And it really opened my eyes. Like in that space, it's really difficult because one of the most important aspects of inpatient psych care is that you participate in group. How do you participate in group when you don't speak the language of where you're at? And after that experience, I started in my clinical orientations asking students, hey, if anybody speaks a second language fluently, let me know, because if I happen to have a patient that speaks that language, I'd love to assign you to them. And that's how I knew, because you shared in an orientation that you spoke Spanish. And so that particular day that you had these two patients, I remember was your med pass day. And I had told you guys that you would have two patients each week other than your med pass day so that you could just focus on your meds. But when I saw that morning, when I went in and started looking through the records that there were two, I remember when you got there, I was like, hey, Tracy, I know you're only supposed to have one today, but can I give you two? And I was like, you only have to pass meds on one, but what I love is your approach that you were like, no, I'll pass meds on both. We did. And then this happened, and this experience in the one being able to address his fears, and then with the other uncovering that he didn't even know how to read in his own language. It just opened my eyes more to the importance of me as an instructor assigning students to these kinds of patients, because we do have a little bit more time that we can spend with them and maybe uncover some of these things and bridge that gap. And one of the things that I love was how when we went to post-conference that day, I kind of just gave you the floor and said, I want you to share today. And so you were able to share with your peers your experience that day. Tell me a little bit about how you think maybe the patient's situations related to finances, fear, language barriers deepened your understanding of social determinants of health, and then how that may have impacted your peers.
Yes. So I do believe that when I take care of a patient, I try to picture one of my family members.
Mm-hmm.
And that makes a difference, but I don't let it be the only thing that makes the difference for when I'm taking care of that patient, because that patient is their own person as well. But I think that this encounter, this experience helps me see that not only my family members have come across things like this, but that it's something that is prevalent in our community.
Mm-hmm.
And so it really opened my eyes to seeing that a lot of people in the healthcare force already don't see it the same way. A lot of them just see it as another patient,
Mm-hmm.
or they see the patient as a diagnosis.
Mm-hmm.
They don't see the actual patient.
Yeah.
And so it helps me to be mindful and know that my patient is more than a diagnosis.
Mm-hmm.
My patient is somebody's family.
Mm-hmm.
And how I treat them during the day can make a difference in not just their healing, but also in their well-being emotionally while they're there.
Mm-hmm.
Because I know that if I was in their situation, I would be so down and sad that, oh my goodness, they can't even speak to me without having to call that line,
Mm-hmm.
type of thing. Or at the same time, too, I think it's important that patients do take some kind of responsibility to being able to tell the person taking care of them, hey, I don't understand this. Can you elaborate some more? Or
True.
not just, there's different types of way of learning. If the patient didn't know how to read, well, let's try and find a translation for the video that we found,
Mm-hmm.
things like that, like addressing their education in different styles. Because even with being in nursing school, I've learned that I'm multiple learning styles in one.
Mm-hmm.
I can be
Hands-on, aesthetic.
kinesthetic, visual,
Mhm.
auditory.
Mm-hmm.
It just kind of depends.
Sure.
And so I think that if we would have caught that the patient didn't know how to read in his language sooner, we could have maybe addressed it differently, like we could have asked the translator, can you read this to our patient or something like that.
Mm-hmm.
And so that's kind of what I did when I learned that the patient didn't know how to read in his own language. I sat chapter and I read it to him.
Mm-hmm.
And even as I was reading it, I was looking at it and I was just like, well, I know what I'm reading, but I'm not. Does he know what I'm saying to him?
Right. Does he understand the health terms, the medical terms that I'm saying, even though I'm giving it to him in his language, there could still be
And even with
disparity.
with MedPass, yeah, I can go in and tell them I'm giving you your antibiotic, which in Spanish is your antibiótico. But sometimes they don't know what an antibiotic is. They just know I'm giving it to them and they need to take it.
Yeah.
They don't have to take it. They can always refuse the medication, but they're taking it. Or like they're taking their antihypertensives. They might not know what it's for. Or sometimes I know I've learned, like with my parents are diabetic and they don't have kidney issues, but they take a statin to protect their kidneys because they're diabetic and are more prone to.
They really understand that.
Right. And honestly, I didn't know that.
Sure.
I just learned that now being in nursing school, you know? And so I was able to even educate my own parents why they're taking the medications they're taking, even though they don't have the diagnoses that those medications are typically used for.
I think you're touching on a really important concept, which was something I was going to ask you about, and that was what gaps in the healthcare system became more visible to you during this experience. And I think that that's what you're touching on. But again, those assumptions that we sometimes have, and in okay, now we've given it to you in your language and you should understand all these terms. No, just like English speaking, we always say in nursing that we should provide education at about a 5th grade level, because we shouldn't make assumptions that, like you said, people understand what an antihypertensive is. Sometimes I even tell students, even more basic than that, we often get caught up in guard nursing lingo or medical terminology or acronyms. And, you know, we might say something to our patient like, have you voided today? And they're like, what does that mean? I know it feels uncomfortable sometimes because we want to be so professional as nurses, but sometimes you just have to say,
healthcare is uncomfortable.
Have you pooped? You know, as opposed to, when was your last bathroom?
And your patient knows you're going to ask them, have you pooped today? Have you passed gas today?
They don't always understand that when we say bowel movement, what when they're like, right. So sometimes you just have to use the lay terms that we sometimes beat out of you during nursing school and say, you know, these are the terms we use. But sometimes we have to with our patients because they understand.
And sometimes even when taking care of somebody in Spanish, I will tell them, hey, my Spanish is not going to be the most professional, but we're going to be able to understand each other and communicate with each other. I'm not going to use cuss words or anything like that, but it's not going to be like professional, you know, like the correct way to say something. But me and the patient will be able to communicate and they'll be able to reply to me and things like that. And even with taking care of patients, inpatient, and their English speaking, sometimes you just got to dumb it down for them and dumb it down for yourself, you know, because not everyone uses, sometimes even us, we don't know the terms that we're using, like it's like that. Like I know I came across like so many procedures that the acronyms for them and I'm just like, what? So I'm just like, okay, keep calling it that because I'm not going to remember the long name for it.
Well, it's funny because as an instructor in, again, acronyms in healthcare, we have so many of them. And sometimes students will stop me and they understand what I'm referring to, like STDs. They know what STDs are, what they do, but they're like, wait, what does SCD stand for? And sometimes I have to stop, like, wait, I have to think about this too, because we use these terms so much.
So often that's what we name them and we call them.
Stuff. It becomes its name and not just an acronym. And so then I have to stop and think, wait, what does it mean? Sequential compression device. And sometimes I can't remember what it is. I'll get back to you. I need to look it up because I can't remember. I know what it is. I know what it does. I know.
But I don't remember what it stands for. We're like letter
verbatim. Yes, exactly. I'll tell you, this clinical experience that day for me during high school, college, I took a lot of Spanish classes, but I am by no means fluent. I am better at sometimes hearing and understanding, picking up enough words that I can kind of understand. But I remember saying to you, okay, when we go in and interact, you're going to have to translate for me because I'm not going to know what's going on. And that was an interesting experience for me, seeing you rise to this occasion and take on these 2 patients when it was just your single med pass day, and then the interactions that you made with them. And then going back and sharing in post-conference and being able to share with your peers about these individuals and the things that they were navigating that we would have never understood as non-Spanish speaking, me as an instructor and then your peers. But one thing I might get emotional, but you know me, I get emotional. Anyhow, one of your peers in that clinical, I ended up having him in the summer in a mental health clinical. And one day we went into the locked unit. Again, we were going in and I had assigned him a client at the beginning in orientation. Anybody speak a language? I did that whole thing and nobody did. But on that particular day, when we listened into a report the nurses were giving, the nurses had shared that one of the clients, I can't remember what language he spoke. It was not Vietnamese, Burmese. It was Burmese. And after listening to their report in the morning, this student came to me and he was like, I want to take care of him. I was like, Zach, you speak Burmese? And he's like, no. He goes, but I want to take care of him today. And I was like, okay. So we switched and he took care of him. And obviously he had to use the language line, but he really tried to add that therapeutic communication, which was amazing because, again, in that space, you're even more isolated as a non-English speaking patient than even in the hospital, I think, where you have access to family members at least coming to you and being able to speak to you in your language versus in a locked unit. You don't have somebody coming to visit you. And so nobody speaks your language. And the only communication that you have is through an interpreter. And you can be there several days. From that experience, me as a clinical instructor, not only did I start asking in orientation, do you speak another language? Love to connect you. Or if you don't speak another language, but you would like to take care of a patient who doesn't speak English, I'd love to connect you. And I just finished a med-surg clinical this spring. And at the beginning, one of my students was like, I would. There was a day where, again, there was a Spanish-speaking only patient. So I was like, Sarah, do you want to take care of him? And she's like, absolutely. She did. Fortunately, his family was at the bedside, so she really didn't have to use the language line too much. But it became a really great experience for her too, and for Zach. And it all from this experience and the impact you made in taking care of those two patients on me, and then being able to impress that upon them and share this story. And then something that you didn't know, again, back to the impact it made on me, I ended up taking this as a case study and I submitted it to 2 nursing conferences because I wanted to speak on it, because I became very passionate as an instructor that we should not avoid these situations. We should embrace these situations because these patients, again, going back to as a nurse, when you have 5 patients and one doesn't speak the language, it's hard. And not that you don't give them the same level of care, but that therapeutic relationship and therapeutic communication is sometimes lost. But being able as an instructor to assign a student to where this is their only patient they're taking care of, or one of 2 patients they may be taking care of, they can kind of give that extra attention that may be missing from just their assigned regular nurse. It's made a huge impact. And I was able to go to these nursing conferences and share that evolution of me as an instructor because of this experience with you. So I want to thank you for that.
That makes me very happy to hear, Misty. It really does, because I think that in nursing school throws a lot at you.
Mm-hmm.
It throws a lot at you, both mentally and I would say also with the way you care for people, your compassion, your empathy.
Mm-hmm.
I think that having empathy is something that should naturally come to people.
Mm-hmm.
And I think that a lot of my peers also took that as a learning opportunity, that clinical day, especially the one student that also worked on the floor and then realized like, oh my gosh, no wonder, like I was trying to communicate with him and stuff. Mm-hmm. I think that it's important to stop making so many assumptions, not only with your patients that don't speak the same language as you, but with patients that speak the same language as you.
All of them.
Yes, because a lot of the times I know within our culture, a lot of the time people don't go and get the care that they need because they already know
how they might be treated.
And I've learned that with working like outpatient right now too, when I'm rooming a patient, when I ask them, what have you tried at home? You know, I usually get like the Sudafed, Mucinex, things like that. But when I'm speaking to them in my language, we're speaking to each other in Spanish, they can tell me all the home remedies that they've done at home that we typically use
over the counter, or more of your herbal, your old wives' tales of yes.
Mm-hmm. And so I think that healthcare it's a big melting pot.
Mm-hmm.
It's not just, it can't be just black and white, unfortunately. I know they say it is and it should be, but there's a lot of gray.
Mm-hmm.
There's a lot of gray, and there's more than just black, white, and gray.
Mm-hmm. I think that as an instructor, for me, one of the things that has been eye-opening and you kind of touched on this in nursing school, we put a very heavy focus on the science of nursing. We have to teach you all the things, the pathophysiology, the pharmacology, and rightfully so. It's important. You have to pass the NCLEX at the end of the day so that you can be a nurse. But I think that sometimes we miss the art of nursing, and that's exactly what you were talking about: the empathy, the compassion, therapeutic communication, therapeutic relationship. And that's something that is so important to me personally, the empathy and communication. I definitely try to bring more of the art of nursing into my style of teaching because, I'm a firm believer at the end of the day, we have to teach nursing students not just like how to effectively care for themselves before they can take care of somebody else. Yes, you need to know all the science stuff, but that's the art of it, in being able to show empathy and compassion and to dig deeper with a patient when they have fears, they feel isolated, they're depressed, whether they speak our language or not, and be able to get to the heart of that. And that's the art side of it, and the thing that we probably don't do so well at teaching. Maybe some programs do better than others. I've taught in 2 different programs now, and I just see a heavy emphasis on the science. Like I said, it's important. We got to pass boards, but we also need to think about the art because we need you to be resilient so you stay in nursing and not get out into the nursing world and realize, wow, this is really hard. This isn't for me.
Yeah. And I know that sometimes being too compassionate can make it hard for you, but it's all about a balance too.
Absolutely.
And at the end of the day, you can't care for your patients if you don't know how to care for yourself.
Absolutely.
You have to be compassionate to yourself as well, and just make sure that you show up 100% for not just yourself, but for your patient.
Yep. Do you think that this experience changed how you would define advocacy as a nurse and how you advocate? In what ways do you think?
Yes, because if that were my family member, if that were my mom or my dad, and they were being cared for, they're being cared for, but they're missing out on information. With this patient, it was important that he received the information since he was getting a PICC line inserted. Mm-hmm. If that were my parent, I would have been upset at the fact that they're kind of just assuming, again, that the patient can understand.
And if you hadn't been there that day, he potentially could have agreed to something that he didn't really understand. Well, it's a fairly benign procedure, quote unquote procedure, to put a PICC line in. It still comes with some risks. And he would not have had any understanding really about what they were doing to him. They would just be doing something to him, and he would potentially have just gone along with it because, again, sometimes I think patients come into hospitals with this power dynamic. Oh, you must know better because you're in this position as doctor, as nurse, as whatever. I should just do whatever you say. But we want patients to have the autonomy to choose it, with that being able to understand what's going on.
And that also just made me remember this other clinical experience I had during a different clinical where I got to observe a NG tube being placed on a patient. And again, this patient, I believe, was of Indian background, and they did not speak any English, did not have any family at bedside, were of elderly age. I remember just watching the nurses just shoving the NG tube in her nose and her not even knowing what's happening to her, not even knowing to tuck her chin or anything like that.
Because they couldn't communicate those things to her.
No. And I just felt so powerless as a student just standing there.
But seeing it happen and feeling like this isn't right.
Yeah. Like they could have at least pulled up an interpreter iPad or something. I believe this was at, want to say what was the healthcare system, but I remember why it was. Yeah. So, but it was just different. I was like,
what are we doing?
What are we doing? Like, there's so much lacking here. Like, this patient is already probably scared because they're in the hospital, don't know what's going on, don't have any family at bedside. Now they're getting something shoved down their nose, down their throat.
And they don't know what is going on.
And it's probably hurting them because they're just shoving it, and the patient doesn't know what correct position to be in.
It's supposed to be, or what they're supposed to feel, or what what they're
And I
supposed to be
remember
experienced as normal or abnormal.
And I remember just watching how they would try like maybe 5 different times before they finally got it in place because it kept coiling at the back of the throat.
They might have been resisting too, and they didn't know how to swallow, and
Yeah,
because they couldn't understand that.
correct. And the patient probably didn't know, oh, maybe if I do this, it might feel better or help, Because again, they don't know what procedure is being done.
I had kind of a similar situation. This was not a non-English speaking patient, but in this last clinical I had, there was a patient that needed a fully anchored, and the nurse asked if one of my students wanted to do it to get the experience. I'm like, sure, we'll go do that. And we went in to do it. And so I wasn't familiar with the patient. None of my students had been assigned to the patient. We were just taking the opportunity to do this skill. And as we started, the patient was like, no, 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 and like saying no. And the tech who worked on the floor was in to assist us. And I was like, whoa, stop. And I looked at the tech and I mouthed, because I didn't want to be offensive, but I mouthed like, is she in her right mind? And what I was getting at is, does she have the ability to consent or refuse? And the tech that worked on the floor said yes. And I was like, okay, well, we need to stop because she's saying no. And then I asked her, if you don't want this, you can refuse, but here's the reasons why we were doing this and why you needed a catheter, a urinary catheter. But if you're saying no, we can't continue. And then she said, no, 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 I know, I'll do it. Yes, do it. And so we tried again. And the whole time she's like yelling, no, 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 no. But at least in that situation, I knew she understood. And that was where I was like, whoa, we can't, because then we start trending into battery assault because we're doing something that they're saying no. And again, I didn't know her. And so I didn't know what her mental state was. And so that's why I was like, okay, stop. Do you want this? Do you understand why you're getting it? Do you understand if you don't get it, what's going to happen? Because she was unable to void. She needed a catheter. And she was agreeable. Yes, I understand all that stuff. Go ahead. You didn't do. And then again, no, but it's just that fear too. And we have to be able to navigate and address those fears and not just do things to people because we see them, like you said, as their diagnosis and not as an individual, and look at that person as the individual that they are. Tell me, what does compassionate care mean to you?
Compassionate care to me is somebody who's able to respect me as an individual and not just as the diagnosis.
So we've talked about a lot of things and a lot of deep conversation. So I want to lighten up as we wrap up a little bit. And I'm going to do a quick lightning round of questions called this or that. Again, just to lighten up the conversation a little bit. And I'll give you 2 things to pick from. And you tell me which you prefer. So let's start. The first one is NCLEX prep questions or SimLab?
SimLab.
Pharmacology or pathophysiology?
Patho.
Nursing school group projects or solo presentations?
Solo presentations.
Post-clinical naps or post-clinical crying?
Post-clinical crying myself to sleep.
There you go. Combination of both. And then lastly, clinical instructor nearby or completely independent?
Completely independent.
Nice. Well, as you're approaching the end of your nursing school career, I would expect that answer. So as we close, I just want to end our conversation with something reflective. What do you hope listeners take away from this clinical experience that you had?
So I hope that we can all learn to stop making assumptions about our patients. I know that it's easy to kind of make assumptions and judge our patients by their cover or their diagnosis, but try to put yourself in their shoes. How would you want to be treated if you were in their situation?
Excellent. Thank you so much for sitting down and talking with me today. Today's conversation reminds us that nursing is never just about tasks or charting. It's about seeing the person behind the diagnosis, recognizing fear behind silence, and creating safety through compassion and communication. If this episode resonated with you, share it with another nurse, healthcare worker, student, or someone who needs to better understand the human side of healthcare, because some of the most important parts of nursing never make it into the chart. Thank you for joining us for another episode of Care Beyond the Chart, Strength Behind the Scrubs. I'm Misty Burgett. Take care of yourselves and each other.